Hello, I will be talking about the National Video Consultation Service and how in Wales we are embedding and scaling up innovation. This service is funded by Welsh Government and the team have been on a roller coaster ride since beginning of March. I'm a child and adolescent psychiatrist who was seconded as the national clinical lead to support the rollout of video consultation as an emergency response by Welsh Government to COVID. This was to ensure that health and social care was accessible to people during lockdown. The principles align with a healthier Wales, which is bringing care closer to people's home, and this was enabled using a video consultation platform, Attend Anywhere, which is safe and secure and does not need any download. I've had previous experience of using Attend Anywhere pre-COVID when I was involved in the Health Foundation funded project Kuch, which was connecting with telehealth to children in hospitals. We provided video assessments and support to young people who were admitted to pediatric ward following self-harm, but soon realized that this model could be replicated in the community and extended, offering appointments to patients and families as follow-ups in schools in primary care. And Kuch was used as an exemplar by Welsh Government to roll out the national program. The technology enabled care team is hosted by an RN Bevan University Health Board and has been instrumental in rolling out this service during COVID. Where video consultation was beneficial during COVID was for those who were with flu-like symptoms of confirmed coronavirus or quarantine to have access to health care while they were isolating. Also, it enables services to continue delivery of care by ensuring that patients were kept safe and care was available in their home or comfortable settings. It was also for those patients in hospital with coronavirus to have access and contact with their families and friends. It also enabled staff who were quarantined but fit to be able to be working to continue working during this difficult time and provide additional health care remotely. In terms of benefits for patients, we know that video consultation improves accessibility, patient choice, and offers access to care for the most vulnerable and elderly, which we have seen in the care homes work that we have done. It reduces the need to travel and makes us a much more eco-friendly service that we offer, reducing time off work, school, and other responsibilities. Similarly, for clinicians, it reduces travel time, parking time, which can often be a nightmare, and has enabled clinicians to work from home, especially when they were self-isolating. But moving on in future, it will help in improving work-life balance. There are certain features such as the meeting room, which has allowed clinicians to link up and continue with their multidisciplinary team meetings and professional development during lockdown. So video consultation was rolled out in different settings, and I will talk bit about that, starting from primary care and now having moved into secondary, community care homes, dental, optometry, pharmacy, and the list goes on. The minister announced beginning of March, 9th March to be precise, that we needed to start providing care for the public and ensuring that they have access to their GPs. The initial focus was on primary care and enable people who were self-isolating to get the care they needed, but also for GPs who were working remotely. Within less than 9 weeks, we rolled out the service to more than 90% of GP practices, and in the last 6 months, we have offered more than 8,600 consultations. This service was also enabled in some of the out-of-hour services and the 111 service. The quotes at the bottom reflect some of the feedback we've had from clinicians and families as to the impact the video consultation has had on their lives. We are aware there's a lot of variation in Wales geographically, and sometimes even going to a GP practice may involve a travel of a couple of miles, which was difficult in these tricky times. Easter weekend, based on the feedback we had from primary care and the way things were moving on, the minister announced the rollout into secondary and community care, We started with the secondary prioritization tool, obviously starting with the COVID wards, palliative care for those who were most vulnerable but needing the help and needed to be protected and were self-isolating, the hospices, frailty ward, hematology, intensive care, mental health, camps, therapies, and as of now, we've moved into 100 specialties and services, having provided more than 27,000 consultations. We went into partnership with Digital Communities Wales as we were mindful there was huge need for providing care and support to care homes. Training and equipment was provided to care homes, and along with this, connectivity and Wi-Fi, which was identified as a barrier for a lot of care homes, was addressed by providing data packages to some of the staff and residents. This enabled the GPs to do virtual ward rounds and cast their eyes on some of the people who were isolating and at high risk. We've also been working with the Digital Coach program in supporting some of the work they are doing with care homes around peer support. Other settings where we have enabled video consultation has been prisons, although there have been some challenges around information governance, schools, especially pre-COVID. As part of Kuch, we had started working with schools. Unfortunately, we had had a couple of suicides in our local health board, which meant that the referral rates from schools had increased, accessing more and more support from CAMs. And during these times, the threshold for CAMs usually tends to go down, but the demand tends to increase exponentially. We started offering clinics to young people within the school setting, which enabled them to get help but also skilled up the teaching staff. And this is something that we were keen on visiting again. Now, in view of the lockdown and limited access to schools, it's going to be an opportunity to work closely with schools to enable children and young people in schools to have access to assessment and intervention from health and social care. Similarly, with the Welsh Ambulance Service, and looking at working closely with the police, liaison services, and mental health teams to provide assessments and support out of hours and in crisis. In terms of groups, we were running groups pre-COVID for the past 5 years within our service in the child and adolescent mental health. These were groups that were run by various professionals from health and education, including speech and language therapists, dietitians, occupational therapists, educational psychologists. We had some parent champions who joined us in delivering these groups, which made it even more powerful. We had tried various platforms, including Link, Skype for Business, and are aware that Attend Anywhere has some limitations in terms of delivering groups, but are doing an option appraisal of all the platforms available, as there is going to be a need for post-COVID groups in the new normal, with community centres being closed, social distancing being available. Therapies, oncology teams are very keen to provide support to their patients and families. We know that change is inevitable, except we need to be mindful of how we deal with it and make it sustainable. We were lucky, as beginning of the program, we joined up with Health Foundation to develop a robust evaluation framework to make sure that we were constantly evaluating and learning and improvising as we went along. The initial phase included surveys that were included at patient and clinician end to capture their experience and satisfaction of using video consultation. We've also rolled out public and professional surveys and have had team retrospectives which have informed and have provided rich data in terms of moving ahead. As the dust settled, we started with interviews with patients, clinicians, and stakeholders, and have done about 150 interviews and have got loads more to cover. We have been in collaboration with a couple of universities and academics and are now looking at case studies and performance metrics. This is what the driver diagram looks like, looking at process measures, outcome measures, balancing measures, and how we plan to move ahead and constantly do our PDSA circles and improvise as we go on. This is about our clinical and evaluation. Overall feedback, 85% of participants have rated as excellent and very good. It's higher in patients compared to clinicians, the time saved, carbon footprint and travel, the need for prevention of face-to-face consultation, especially during time of COVID, and the age range, we see there has been an increase gradually over the months of usage in our elderly population who are getting more and more comfortable. This is in terms of the training offered, our website, the toolkits, we've got a huge social media presence, and also in terms of publication and resources. I would encourage you to have a look at our website. We've got toolkits, especially the Kuch toolkit, which has been endorsed by the Royal College of Psychiatrists, which provides safe guidance in terms of safeguarding, consent, confidentiality, and we've got toolkits for primary, secondary, community care, case studies, and stories and publications. As I finish, I would like to leave you with a snippet from the BBC Wales programme that was filmed in one of our intensive care unit, where they talk about video consultation being used for something we never imagined it would be used for, connecting patients with families, enabling them very often to say their final goodbyes.
It's very, very challenging for us. It's not normal circumstances. It's really, really difficult. However, there is a light and a bit of positivity in there. We've had a lot of iPads donated to us, and this helps them. So our patient who is extubated, hopefully in the morning, he can ring his wife and they can have a little video chat.
Mom! Robert! Robert, your wife's on the phone!
Bob, how is
He looks peaceful.
He is. Can you hear?
I love you.
So I'll explain to you now the things that he's got, so you know what all of the bits of support are and the bits of kit. So that tube there goes into his neck, and it's called a tracheostomy, and that helps with his breathing. Okay? So this is all very normal, and believe it or not, it's very normal for people to be sleepy like this as well. Oh, bless him. He's doing well. He's doing well. We've made lots of progress.
I was in the situation for the first time the other day where I phoned a family and said, unfortunately, your loved one is going to die. And I thought to myself at the time, what on earth can I do to make this vaguely human? So I spoke to the daughter of this person and I said, I don't know whether this is going to sound like the most barbaric thing ever or whether it's something that you would entertain, but we can possibly video call the end of life. And she actually said, oh God, that would be great. At least I would feel like I could be there in some way. So we prepared everything and we made contact via video conferencing, and she saw the face of her parent and she said what she wanted to say, what a fantastic parent they'd been, and all the things she wanted to say to him but wouldn't be in a position to. And when she'd said what she wanted to say, we turned off the various vasopressor agents, etc., and amended the alarm settings so that the buzzers didn't keep going off to interrupt the end of life experience. And it was very much like it would have been had she been.
Thank you very much, and this is our amazing team, again keeping the virtual contacts. Thanks a lot.